here or what's that?
No, we'll come back.
Okay.
Ready?
The broadcast is now starting. All attendees are in listen-only mode.
Good morning. This is Peter Lee, the Executive Director of the California Health Benefit Exchange, welcoming nigh on 100 people to the third of 3 webinars the Exchange has been hosting over the last week to get input, discuss, and share ideas with regard to the qualified health plan policies that will be coming before the Exchange Board of Directors at our August 23rd board meeting. I want to remind people that we have actually posted on our website links to recordings and web versions of the prior 2 webinars we hosted last week. And if you did not attend those and are interested in issues with regard to first, benefit design, and second, issues of essential community providers, those webinars are available. Let me tell you a little bit about process and then we'll dive in. We're going to go through some PowerPoints that are part of the webinar. Those PowerPoint slides are available on the website, so if you have trouble being on the web, you can print it out and use it from there. We will pause at different points for comments and questions. We very much welcome comments and questions in either of 2 ways, either by raising your hand and speaking, or through the web you can enter your comments and questions and then we read those off. And it's actually a very useful vehicle because we actually save and keep the comments and questions and use those as input as we're going forward. I want to remind you all that what staff with good work and support from Pricewaterhouse developed a set of preliminary recommendations, and they are just that, they're preliminary. And we're using the time between now and the board meeting to make final recommendations. This webinar is part of sharpening our recommendations to make final recommendations the board would act on, but also are the comments we'll be receiving not just today, but between now and, we hope, August 6th. And we have a feedback form on our website that we welcome you to use and weigh in with comments, thumbs up, thumbs down, and in particular, as specific as you can with suggestions for improvement. With that, before going through the various elements, I'm going to ask Andrea to sort of remind everyone who the team is and where this part of the recommendation fits with the other elements, and then I'll let folks know who else is on the line. Andrea?
Certainly. So I'd like to, our other presenters who are joining us today are Sandra Hunt from PricewaterhouseCoopers and Emma Hu, who is somewhat of an expert in the data collection tool that we're going to be discussing today, Evaluate. She's with the Pacific Business Group on Health Negotiating Alliance. And did you want to?
Yeah, and I'll also note that we have on the call currently Susan Kennedy, one of our board members. We expect to have Paul Fear to join us as well. I will note that the other webinars, every webinar has had what we call our paired board member opportunity, with board members have been listening and participating in each of these calls, and we appreciate Susan making her time available for this call, and encourage Susan to join in with comments and questions as we go through this. Okay? So with that, we're going to go through, and again, this webinar is focusing on what can and should the exchange do to promote quality and affordability, both for enrollees in the exchange and more broadly. We all know that the #1 job of the exchange has to be to make sure we have affordable products available to the people that would be enrolling in the exchange. But we've also noted, and our board has noted, a core value of the exchange is to be a catalyst, to be part of changing the underlying delivery system to make care more affordable broadly. Staff took that charge from the board to heart and have laid out a number of core recommendations on addressing affordability in the near and long term. So I'm going to go to the first slide to provide an overview, which is, in essence, reframes and reminds everyone that our mission of stimulating new strategies for high-quality, affordable care that addresses prevention, wellness, and reducing health disparities means that we cannot be passive. We can't just sit on the sidelines. We need to be conscious. We need to be thoughtful. We need to think about the role that health plans play in supporting where care is actually delivered, which is at the bedside, in clinics, by doctors, by nurses. So what do we do that would create the environment to promote delivery system reform? What do we at the exchange do with regard to promoting payment changes, promoting appropriate measurement, promoting transparency? And those are the core elements that we've provided recommendations on. I will note that we have consistently throughout the staff's development of these recommendations sought right out of the gate to be in alignment with other purchasers, and in particular with the National Quality Strategy, which identifies what many of you are familiar with, the three-part, or often called triple aim, of how are we promoting better care, better health, and lower costs. And that sort of three-part aim is framing virtually everything we do. This slide identifies 5 things that are part of our recommendations, and then we're going to go through 4 of them today, because the issues around wellness and prevention we actually spoke about in the context of benefit design. So the 4 things we are recommending is, first, that we promote alignment with other purchasers, because as big as the exchange is, we believe we need to be working in concert with others. Second, to collect standardized information on what health plans are doing to promote better care delivery payment practices. Third, to require some practices of plans right out of the gate to be as core to the certification of plans to be in the exchange. And finally, to use value elements in the QHP selection process to provide weighting or sort of some elements in value to the selection of plans. Those are the 4 elements we're going to talk about today. And again, the advancing wellness and prevention is central to promoting quality and affordability, but we discussed that at the webinar on benefit design. So first, the area of alignment. The exchange sort of has identified that we need to consistently work in partnership. To our mind, that means working in partnership, as we've been doing with Department of Health Care Services and Healthy Families. It means working in partnership with CalPERS, Office of Personnel Management. It means supporting standardization across other state-based exchanges, because we want to be able to benchmark what we're doing and compare our performance to others. So when we think about alignment, that's all background. That's framing where we seek to approach our activities consciously saying, how is what the exchange doing in sync with activities of those other key partners. In terms of specific formal steps that we're recommending the exchange undertake is twofold. Specifically, we recommend that the exchange actively participate in forming a national, shall we call it, an association of other exchanges. 17 states so far have said they plan to set up state-based exchanges. More are considering it. We believe we have a lot to learn from other exchanges. We believe we have a lot to offer other exchanges. So we think there needs to be a structure by which we can share experiences and seek alignment of value promoting activities. So we recommend that we help form and participate in a national network of exchanges. The second recommendation is that the exchange should join the Pacific Business Group on Health. And I want to note a couple conflict of interest issues here. And they are conflicts, but I want to make it clear. Is first, this recommendation was made not by Emma, who is providing consultant staffing and works with PBGH. Similarly, this recommendation was not made by Paul Fear, one of our board members, who has been chairman of the board of PBGH. This came from staff. Many of you know that I had the privilege of serving as the CEO of PBGH. I am not a shareholder. It's a nonprofit organization. I have no compensation from them. PBGH is a 501c4 mutual benefit nonprofit that has as members public and private purchasers, including CalPERS, University of California, Stanford, Pitney Bowes, Wells Fargo, and has been one of the premier organizations nationally helping purchasers think about promoting value. We think the exchange should be a partner with other purchasers. So we're actually recommending to the board that we engage in negotiations with PVGH to join PVGH. So I'm actually going to pause here briefly, and we'll go through the others and have time for people to have comments or questions we go through, but to see if there's any either questions or comments on the issue of alignment. Because, again, we believe that promoting alignment is something we should be doing throughout what we do, alignment with Medicare, alignment with Medi-Cal, et cetera. I will note, I should have noted that actually PVGH is a 501c3, a charitable nonprofit. It actually has an affiliated 501c4, but it's a 501c3 in terms of describing what the it is. So are there any sort of comments or questions on alignment before moving on to the next section? And again, you can hold your comments and questions till later if we review everything, but any comments now?
I have a question, Susan.
Please, Susan.
In terms of alignment in the procurement strategies, have you identified what any core elements that require alignment or that have sort of elevated that issue to a must-have, let's say with CalPERS? Like what kind of procurement strategies qualify as key to align?
That's a great question, and actually, if I could, Susan, it echoes a question from Brett Johnson of, can you provide examples of the alignment you are seeking, which is very similar to your comment. I'll give you a couple examples. Is CalPERS, for example, has engaged in strategies to have ACO contracts with some of its networks. And the exchange might say, well, we want to have similar strategies and similar measures as CalPERS is using to measure the effectiveness of their accountable care organization. So CalPERS does not do a, so to speak, narrow network or ACO strategy and measure it one way, and we measure it another way. So one core element is around measurement. So we're measuring the same things the same way. Another example of core alignment, and this comes into some of the issues we'll come into in a moment, a number of purchasers are saying we want our health plans to participate in medical home or other structured ways to have better primary care delivered. Well, there's currently about a dozen ways to define what is a quote-unquote medical home. Alignment may not be out of the gate for the exchange saying we think the right way to be a medical home is in this structure. But we want to look at what is the Center for Medicare and Medicaid Innovation doing, what is Medi-Cal doing, what are private purchasers doing, such that we can say, potentially in 2015, we'll say, these are the right 3 models of medical homes, but right now we want to make sure that we aren't creating new ones.
Well, I might just add to build on the metrics example using CalPERS and the ACOs. We're going to be talking about a data collection tool that a lot of large purchasers are using right now next. So a really good example of alignment is if the more purchasers who use this particular data tool, the more robust it becomes and the more cross comparisons are possible. So I would add evaluate
sure,
as an example of alignment.
So is that okay, Susan? I'll move on to the next. Okay. So I'm going to move to the next, which is the second preliminary recommendation, is to collect standardized information on health plans' performance with regard to their care delivery and payment practices in particular to inform our future work. And as many of you know, there is a substantial amount of clinical quality patient experience results that are collected as part of NCQA accreditation that populates the Office of Patient Advocate and other report cards. Those data points, in many ways, we take as a given, and we address more broadly in our accreditation and QHP, Qualified Health Plan Board recommendations on those issues. Going beyond that, though, we think it's important to foster better understanding of what health plans do and to make sure there's transparency in the market at large through a number of things. First is to require completion by the plans of Evaluate. Evaluate is a health plan request for information that collects information on health plan practices. And we're going to go through what some of those elements are in a moment to spell out what Evaluate is. And one of the things we very much want comments on is it all of Evaluate or some parts of it? But currently in California, many of the large plans complete Evaluate, and they go into some detail on things like prevention and health promotion strategies, chronic disease management, behavioral health. Understanding what plans do at a granular level is critically important. The Evaluate tool is something that has been sponsored nationally by the National Business Coalition on Health. It is not just used in California. It's used by literally hundreds of plans across the country, sponsored by purchaser coalitions that say we want to have standard information what our plans do. So requiring completion of Evaluate is one recommendation.
And by the way, I wanted to let everybody on the phone know that that tool is now up on our website, so you can open it and take a look at it. It is secure, so you're not going to be able to print it, but it is there for everybody to take a look at.
And it is a proprietary tool of the National Business Coalition on Health. We are big believers in transparency, and we appreciate NBCH letting us put it out there so people can look at the details of Evaluate and say, boy, this section 1.7 on addressing health equity and disparities really does give a lot of granular detail. This is a pretty good section. This section, not so sure about. I'm not trying to lead the witness here, but we really want people to understand what's in there. There's a lot to it. So we have a question specifically from Amy Sawyer on how is Evaluate different or similar to HEDIS and CAHPS reporting. And they're two very different animals in the sense that Evaluate actually includes using HEDIS and CAHPS data. But what Evaluate does is go into how do plans do what they do, by and large, versus HEDIS and CAHPS are the results of what plans do. So HEDIS looks at, for example, what are the results of performance in terms of better care to diabetics, care for people with asthma, not how a plan structures a disease management program. Similarly, CAHPS, which is the Consumer Assessment Health Plan Survey, is a patient experience survey. It surveys a random sample of enrollees in a plan to say, what is your experience of getting access to care, et cetera. So those are two instruments, data collection tools we absolutely plan on using, but they complement Evaluate rather than being a substitute for it.
And I would say that another advantage of Evaluate, Peter emphasized the importance of Evaluate for providing transparency on plan methodologies, like how do they provide a medical home, how do they provide disease management. But it also opens a window into some transparency about how providers function. And going back to the section 1.7, which we've mentioned in a couple of the webinars, that gathers information on racial and ethnic characteristics. It's not only about the plan and how they deliver services to individuals who have particular ethnic characteristics, but also their providers. So how many providers speak certain languages and how available those providers are, and what the plan is doing to facilitate the provision of care in individuals' languages other than English.
So I'm actually, if folks don't mind, I'm actually going to fly through the next 3 slides to give everyone the overview of how these elements relate to one another, and then come back to Evaluate and throw it open for comment. So the 2 other elements here in terms of standardized information is we do want to continue looking at the Medicare Shared Savings Program and other measures endorsed by the National Quality Strategy to see where there's gaps in assessing care coordination, patient, caregiver engagement. We don't have specific measure recommendations, but the exchange should be part of promoting standardized use of measures that aren't creating new burden, but are using existing measure sets and having those existing measure sets used more widely. Finally, a recommendation is that we would prohibit plan contracts with providers that preclude transparency. So we've heard, and we need to hear more about this from plans and others, that there are some provider systems that prohibit plans from using data on those providers for quality performance information, or that require all providers in a particular network or hospitals, et cetera, to be used rather than allow only a subset of providers to be used. Those are issues that can cut against both transparency and against sort of creating a value network. The next area I'm going to go through very briefly is what might we require right out of the gate. And we might require certain health plan practices to promote better care. In the area of value, we're mindful that we don't want to have a very high bar in our first year or two. At the same time, there's certain things that we think should be, so to speak, table stakes or the ante to get in the game. And examples of that, of potential requirements that we, again, very much welcome comments on, is that every health plan that is in the exchange should provide consumers information about the providers they contract with. We intend at the exchange to have a provider directory. So a consumer enrolling in the exchange can find out that, oh, Dr. Ramirez, that's who I see. Oh, she is currently contracted with these two health plans. That helps my plan selection. We think that's vital at the point of plan choice. As importantly, though, we think it's important that if a consumer finds out that he needs a knee replacement, that his plan would help him understand the choices he has before him, the hospitals in his network, the doctors they could see, and what that might mean in terms of outcomes. We aren't seeking to standardize what that information looks like. We are saying, though, it should be a requirement that health plans provide consumers information at the provider level. Similarly, we think it's a potential requirement that consumers be provided with information on cost of care that is readily available. All of the benefit designs in essential health benefits will have cost sharing. Low income, medium income, high income individuals will be exposed to portions of the care of the cost of care. We believe it's critical that the health plans help individuals understand the implications of the cost to their out-of-pocket cost of the system. And finally, as we noted, the requirement of using Evaluate. These are examples of requirements right out of the gate for certain health plans practices. The next area, though, is besides having requirements, is how might we use value elements in our qualified health plan selection process. So as you all know, California, in our legislation, can be an active purchaser, which means instead of being a, so to speak, any willing plan exchange, saying that we won't necessarily have every plan in. We will evaluate plans on a value proposition. That value proposition is both what the plan costs in terms of their premium and the quality of care they make available and deliver to their those that enroll. Some of the elements we're looking at that we're considering, so to speak, putting a thumb on the scales for are information we could collect both in what a plan does in terms of HEDIS and CAP, but also in terms of the plan's practices. What does the plan do to support pay-for-performance or medical home? And so we've articulated a number of strategies that we think are absolutely critical for any health plan to support, such as promoting care coordination in medical home, such as effective chronic disease management, using data to identify at-risk individuals and populations to help those people get the best care, to have payments to hospitals that promote reduction of hospital-acquired infection, reducing sepsis, central line infection, initiatives to address health disparities, and demonstrating innovation to support for innovations. These are all elements we think, and we've looked at the literature, we've looked at the National Quality Strategy, work done by the Center for Medicare and Medicaid Innovation, are part of creating change in the delivery system that is patient-centered, that is centered around recognizing each person in their family setting, getting the right care at the right time. We don't think we're at a point today where we should say, this is exactly what those should look like, do them these ways. Rather, we want to assess what plans are doing, make sure they're doing active programs in every one of these areas, but it may be that in future years we'd say, we now know that these 4 interventions are must-do interventions with regard to addressing health disparities. You need to do those. Out of the gate, we'd be broader, more inclusive, and require some description of initiatives in these areas and could weight them in the selection process. So that's the issue of using value elements in selection, but also trying to raise the bar to make sure that across the board plans are working in partnership with their contracted provider, with their hospitals, to actually deliver better care. So that's the area of preliminary recommendations on using value elements. The next slides actually go into some detail, and I'm going to ask Emma to speak to this on what is evaluate and how we're asking comments on that. I'm going to actually go to the next slide, which talks about what the evaluate is, and ask Emma Hu from PBGH to describe sort of what we're actually looking for stakeholder feedback on. And again, I do want to appreciate the folks at the National Business Coalition on Health for making available the Evaluate website. You can click on this link on the PowerPoint, which I always think is magic, to get to the RFI during this period to help understand what we might be asking of plans. But I'd actually ask Emma to frame some of the issues we need to decide and ask for your input on. Emma? Emma, we can't hear you. Huh. Well, I'll keep talking then. So let me know what we're asking for folks' comments on, which is the Evaluate RFI is structured by modules. It's got modules on consumer engagement, provider measurement, pharmaceutical management. Our starting assumption is that we would have plans do every module. We would welcome comments from plans and from others on, is it all modules or some more important than others? Emma, do you want to weigh in some more on this?
Sure. So we've lined a couple of questions up around the feedback that we're specifically requesting with respect to the content as well as the use. Currently, there is some structured scoring within the Evaluate tool, and the exchange can opt to weight some areas more heavily, and would like your feedback on that as well. Some of the other components of Evaluate also are structured to support comparisons across both HMO and PPO plans, and you may feel that there are specific questions that are more relevant to plan types or that relate to small purchasers more directly versus large purchasers. So we welcome your feedback on all of those elements.
And so in particular, I'd note that when we talk about scoring in Evaluate, we are not talking about this to be part of what will be coming later for more discussion input. The quality and performance information we would make public on plans. One of the things we need to do as an exchange is have a quality report card, so to speak, on health plans. This scoring relates to our selection of plans to be in the exchange. And so I just want to distinguish those. We'd welcome your comments on that. So,
and I'd like to just point out to people that the link to the Evaluate RFI is in the stakeholder section of our website.
So forget what I said about the link being embedded in the slide. It may be, but on stakeholder, you can go to the link and it's then a hyperlink, and then you don't need the deck to link to it. It's on the stakeholder section of our website to link to the full Evaluate RFI. Okay. So we have a question/comment from Ramla Saeed, who notes, will healthcare plans be required to provide reimbursement to clinics who must hire and train a more adequate medical interpreters to communicate with limited English proficiency patients to ensure that non-threshold languages also have access to quality care? I think this is really really a core issue in many ways that relates to our network design issues and provider adequacy. And I note that it's a central requirement both of the exchange but also under regulatory standards that providers need to have access to providers that are language sensitive, language appropriate. In terms of the reimbursement, whether it's to a individual doctor's office, a clinic, etc., the exchange isn't requiring particular reimbursement terms. The issues of reimbursement between plans and providers is a matter of market negotiation between them. We, at the exchange, will make sure there's adequate networks. We also will make sure, and it's a great question, we appreciate other comments on this, that, for instance, on our directory, we identify having what languages are spoken by providers and those issues. The issues, though, of exactly how interpreter language support is provided is again, we welcome comments and thoughts on that. It's an important issue for network adequacy and also for competent delivery of care.
So I'd just like to say on the first question about will the healthcare plans be required to provide reimbursement to clinics who hire interpreters, there is current state law and regulation that basically does place the onus on the plan, not on the provider, to make sure that there is medical interpreters for people who are not speaking English when they request it. The manner in which they do it, in other words, whether they use an AT&T operator or whether they have a face-to-face medical interpreter, is not dictated by statute or reg currently. It is certainly something the exchange could consider, weighting a plan more highly if they do make arrangements to have face-to-face medical interpreters. But again, we're not at this point recommending going above and beyond what the current statutory and regulatory requirements are. But those are in place, and our plans will be required to comply with those as well.
So we have a comment or a question from Kevin Knaus noting, can the cost estimators be designed to give the consumer a breakdown of the various specific procedure as opposed to just a lump sum? And this is exactly, it's a great comment and question. One of the things we'll be looking at is that if we require, as we note, that cost of care information is readily available, making cost of care information understandable is not a simple act. And I think your question notes this. How do you break down both a full cost of an episode, but then break it out by different elements? Different plans have done this in different ways. I don't know that it's clear exactly the perfect way to do it, but it is, we would want to both see what the plans are doing, see what works, assess it, and again, build on it and improve it over time. Okay? So that relates to the issue of requiring cost information to be readily available to consumers. Okay. So I want to go to a couple of the other issues with regard to evaluate just very briefly, just to encourage you to look at the detail. As Emma noted, there's a number of modules that are in Evaluate. They're robust questions. I'm not going to go through the detail of the slide notes. For example, Section 1.7 on racial, cultural, language competency has a very rich set of data points to understand what is a plan doing to support member needs that have limited English proficiency. And then, do they negotiate discounts and interpreter services provider networks? Do they train ad hoc interpreters? Do they provide or pay for foreign language training? Now, these are not areas where the exchange is saying a plan must do this or must pay for it. But a starting point is let's understand what plans are doing. And so we think Evaluate, as an example, is a very good tool to understand a starting point, understand best practices, and then gives the exchange a way to say, boy, 5 plans are doing this, and this appears to be very effective. You 2 plans, why aren't you doing that? So it engages, gives a tool for the exchange to engage in good partnership discussions with plans around something we think is a common mission we have. So this just gives you an example of the texture of what is in there And they go on in terms of the range of plan activities that are sought of what is a plan doing in terms of, for example, on the next slide we talk about how does a member support plan's live outbound telephone management program? What is a plan doing to do self-management engagement, et cetera, et cetera. So again, the Evaluate instrument does a high review of what are in these modules. And I'm going to ask Emma very briefly to do a high-level review, if she could, of the basic modules so people get a sense. Evaluate's a big document, and so getting a heads up on what to look at in these modules I think would be helpful. Emma, would you mind walking through and do a high-level review of the content of the modules?
Sure. As I noted, it's organized into 7 modules. Within Plan Profile, we have some of the high-level information about health plan accreditation, their programs and services, and the extent to which they use subcontracted vendors, as well as the disparities and cultural competencies section that Peter just described. Within consumer engagement, we take a close look at the availability and functionality of consumer-facing tools such as provider directories, the level of interactivity that's available in those tools, as well as cost calculators, the extent to which they are specific to procedures or providers and local to contracted rates in a specific market, per the question that was asked earlier. Another category that the consumer engagement section looks at is shared decision-making, the extent to which health plans provide tools to support beneficiaries in understanding their treatment option choices at the point that they're evaluating providers as well as types of treatment. Within the provider measurement and rewards section, we drill down on the use of measures for physician and medical group measurement as well as hospital measurement with the goal of promoting the use of nationally standardized measures and the extent to which health plans are compliant with elements of the patient charter with respect to measuring providers and allowing opportunities for provider feedback. We also drill down on specific areas of patient safety and align with Medicare policies in value purchasing to look at ways in which plans are focusing on reducing readmissions as well as avoidable complications that have an impact on overall affordability and cost. We also focus on promoting areas where plans can undertake payment redesign strategies such as bundled payment or other types of contracting that support alignment of financial incentives across systems. In pharmaceutical management, there are a range of questions that look at the efficiency of management in the pharmaceutical area, including how plans manage specialty drugs, as well as specific categories of patient safety within drug management. In prevention and health promotion, beyond some of the traditional HEDIS assessments of preventive screenings and cancer screening, this area also looks at the health plan tools for health risk appraisals and the way in which the information is organized and shared for use in supporting condition management programs. There are also sections specifically geared towards weight reduction and obesity management, smoking cessation support, as well as maternity care. In the chronic disease management area, there are a number of questions that drill down on diabetes and cardiac care, focusing both on the tools and information that is provided to physicians and medical groups, as well as member support, such as the examples that were shown on the previous slide. And then in behavioral health, it's set up in structure similarly around provider support and member support, as well as incorporating the results of HEDIS measures. So that, at a high level, are some of the basic contents of the 7 modules.
And I would note that the Evaluate RFI itself is over 170 pages long. It's got a lot of detail in every one of those modules. and let me note there's two questions that have come up that I think are really very helpful from Megan McCammon is, what are we going to do with this information? And again, I want to underscore that we'll use this in a number of ways. Number one, we would potentially use this to help our selection of qualified health plans, to score elements here for selection. Second, though, we believe the exchange needs to be a partner with health plans, and that health plans need to be partners with clinicians, with providers. Partnering requires information. We want to understand what the plans that we are working with are doing. We would use the evaluate information as part of our regular engagement process with health plans to improve what they're doing, improve what we're doing. So it would be a tool for better engagement with our health plan partners. And the third thing we do with this information is, I noted early on that we look forward to learning from other exchanges around the country. Evaluate can serve as a platform to actually understand what other plans are doing in other areas, what other exchanges are doing. So when we think about benchmarking and measurement at the plan activity level, Evaluate provides information from which we can actually compare and contrast what are the plans that are part of the California Health Benefit Exchange doing compared to those in the Maryland Exchange or those in Oregon or those in Washington. And having a standard way to ask the question, to understand what we're doing across the country, we think will be vital to understanding which particular intervention makes more of a difference.
And I would add there's a fourth way that we're anticipating using the evaluate information, and that is as we go forward in the future to the recertification and decertification process, we will try to refine our criteria, and we can do that based on information. We may be able to do that based on information we get from Evaluate, so we can continue our commitment to evidence-based criteria.
And finally, we may, and again, some large employers have used information collected in Evaluate to give their enrollees information about what plans do. So in describing what chronic disease management programs a health plan has, some large employers use the Evaluate information to say, you have diabetes, here's what the 3 plans we offer as a large employer do for diabetics. So we'll look at the Evaluate information to potentially be used to provide consumers with information about what programs are offered within the plans offered by the exchange. So we have another, yes, please.
This is Paul. I just have a question with regard to the Evaluate information, actually a question and a concern. A lot of this is program description, in other words, in terms of the consumer engagement tools and health and wellness programs, et cetera, et cetera. To what degree in Evaluate or in our processes that we contemplate, are we going to gather information about utilization of these services and programs? So the concern would be they may have very elegant programs that are just sitting on the shelf gathering dust. The really critical issue is utilization of these programs.
Yeah, that's spot on, Paul. And again, one of the nice things about Evaluate is many of the questions ask both. They say, for instance, do you administer a health risk assessment? And if so, what percentage of those for whom it's administered actually complete it? So Evaluate, while I did note that it is anchored in descriptive of the processes that plans do, it also collects data on utilization and where it's possible effect. Is that correct, Emma?
Yes, and there are also specific questions about measuring the impact of specific processes and engagement in those tools.
Okay, we have a question from Micah Weinberg. Would the IHA pay-for-performance program be an example of something that would qualify under provider measurement and rewards? Absolutely it would. And this is a great comment. Is first, Evaluate has, in responding to Evaluate, every plan in the California market that is participating in the pay-for-performance initiative would describe that through Evaluate. That's an example, though, of is that something that we think should be a requirement? We need to look at the sorts of elements that we think every plan should do, our starting point throughout these efforts is to be a partner with plans, to not be have a heavy stick, so to speak. But there's certain things that we probably all think that plans should all be doing. But absolutely evaluate, we collect that, and then the board, in discussion with others, can decide what should become over time standard. We have another question from Julie Silas with Consumers Union. In Evaluate, do plans self-report? If so, how have those who have used Evaluate monitored or held accountable for self-reported data? How are we sure the data is accurate? Emma?
There's both self-reported data and information that we bring in from other sources. So the HEDIS data, for example, is fed directly by NCQA. With respect to specific questions, there are verification procedures, and frequently specific documents are provided to validate a response and used in the discussions that we have with the carriers on feedback. So examples would include print screens that demonstrate some of the web tools or documentation of some of the outreach letters to providers.
Great. So we have another question from Brett Johnson on the point of partnering required information and the statement of wanting provider-level performance information from the outset. The question is, what type of provider-level information are you seeking for reporting in October 2013 into the 2014 plan year, and at what provider level? E.g., Massachusetts does hospitals and medical groups. Is that what we're looking for? This is a great point that we're seeking comment, and we want the plans, consumers, clinicians, hospitals to weigh in. California has a long history of different levels of quote-unquote provider-level reporting. Many plans have some sorts of information out there. The exchange is not seeking to be the decider, so to speak, of the right way to promote provider information, nor do we want to create whole new systems. We do want, though, the millions of individuals that are going to be in exchange plans to have information that is relevant to their choices. We know that one of the big challenge issues there is of most relevance to many consumers is not just hospital and medical group information, but actual individual clinician information, which is an area that is challenged by absence of really good information. This is an example of where we would look forward to partnering with, for example, CMS, which has a major initiative to have physician quality reporting and to put online physician compare information. How might plans put that information out there, et cetera. So we would welcome comments on what should be standard as of 2014 and what might be built to over time. Okay? I'm going to go to the next few areas. Besides the areas of Evaluate, there are 3 other areas we wanted to surface and get folks comments on, or make sure people have the opportunity to comment on later. And they relate to accreditation, administrative simplification, and our partnering with health plan issuers to promote enrollment. So next I want to sort of go to the area and have Andrea walk us through the issue of accreditation standards, which again goes to the issue of promoting high quality affordability. Andrea?
So first I'd like to remind folks that the accreditation requirement is specific to QHP and is not one of the market-wide requirements of the Affordable Care Act. We made our initial recommendation at the board meeting on July 19th, and that is to require, it's kind of a combination recommendation, to require the reporting of certain caps and HEDIS measures consistent with Medi-Cal managed care specifications, and to require an interim NCQA health plan accreditation by 2014 with a goal of achieving commendable by 2015. Now the reason that we are starting off with interim is in recognition and to encourage new entrants into the commercial market in order to participate in the exchange. And by having an interim status that will allow those new entrants to at least achieve, be on the path towards accreditation and not be barred from participating in the exchange. Actually, during the meeting on July 19th, we were informed by the Fed that we need to acknowledge URAC accreditation, so we will be amending this recommendation to the board to include that requirement. However, we are, because of our belief and because of our belief in the value of NCQA accreditation, we're seeking guidance as to whether we can place greater weight on NCQA accreditation while complying with the requirement that we acknowledge URAC accreditation.
And that's an issue we would welcome comments from stakeholders on. So let's move on to the next area.
Sure.
Which is the issue of administrative simplification.
This is also a QHP-specific requirement of the Affordable Care Act, but we think it will have market-wide benefits. We don't think that changes in how the plans operate in order to meet QHP requirements will be done solely for QHPs. Obviously, it will benefit the outside market. So we're looking at the three requirements. Verification, efforts to standardize verification and claim status. Eligibility, we've heard a lot from providers that this would go a long way towards reducing waste in the system if there was a standardized approach to verification of eligibility and determining claim status. So we'll be gathering information on that and encouraging QHPs to give that their best shot. Similarly, electronic funds transfers, payments to providers by health plans. There is an effort to establish and adopt transaction standards to eliminate paper checks, and we're going to be asking the plans to continue to move in that direction. Peter mentioned earlier our commitment to consumers who are shopping and selecting QHPs come end of 2013 to be able to get provider-level information as part of that shopping experience. And the only way that will occur is if we require / encourage the plans to gather that provider-level information and make it available. And this is the issue of transparency. And we're going to be trying to approach that in a standardized fashion so we can actually use the information eventually on our website for consumers to see information about the providers that are participating in certain health plans.
Let me just build on this for a moment if I could. So the Affordable Care Act doesn't have specific administrative simplification requirements for qualified health plans. It does, though, have these three, a staged process to try to make the entire delivery system less burdensome on clinicians, administratively more simple. The United States healthcare system spends more on administrative crud than any healthcare system in the world. The exchange wants to be mindful about what we do to not add to that crud, but also, better than that, how can we help take costs out that are not costs in delivering care? These are some examples. We very much encourage suggestions. There have been some important efforts over the years in California to try to standardize credentialing, things like that. The exchange does not now have a hard set of recommendations here. Rather, we want to have this area clearly on our radar. We want suggestions from plans, hospitals, doctors. What can we do to reduce administrative costs? So more dollars are going for actual care. And I want to note that unlike the format of a lot of these other slides, these three columns are not separate options and recommendations. Rather, this is showing what's coming down the track under the Affordable Care Act. And so we are going to be looking at opportunities over time. And again, this is an area where we do not have a specific set of requirements. We do not have a specific set of health plans must do this. Rather, we wanted this to be on the delivery system's radar. It's on our radar. We know it's on plans' radar. We're certainly mindful about not adding burden, but better than that, how can the exchange be part of reducing burden? So that's what this topic is. Again, I will confess it's not well developed. We need to develop this not between now and August 23rd. This is something we'll be working on a lot in the months and years to come. Okay. With that, we're going to go to one last area, which is in some ways another issue area, somewhat distinct and separate from affordability that we shoehorned into this webinar. So all the areas up till now have been on the issues of promoting affordability and quality. This is an area with regard to how does the exchange partner with health plans issuers to promote enrollment. Okay, and this is a critical area. Is health plans sell insurance? Health plans have current enrollees. Health plans should be vehicles to maximize enrollment insofar as we can in a way that is consistent with the exchange's mission. And what we've laid out in our brief is a set of preliminary recommendations for fostering planned partnerships in 5 areas. And I want to underscore in particular both a philosophy that's embedded in them and then a very practical issue that we'd like to make sure people are clear on so they can weigh in and make comments on, which is we want plans to share with us what they're doing in marketing and enrollment. So that's the first recommendation, is that we would hold it closely, but we don't want to be wasting our money by doing the exact same marketing a plan is doing at the exact same target. We want to be able to coordinate and understand that. So having plans sharing their marketing strategies and enrollment activities is something we would want qualified health plans to do. Second area we are considering, and this is not out of the gate, but something we are considering for future years, is to, so to speak, incentivize issuers to market on behalf of the exchange. The concept we have proposed, and again, we are not proposing this to be implemented in 2014, but it might be in 2015, would be if, for instance, the assessment for being in the exchange is 2% of premium, we would give a credit against that 2% for marketing dollars spent in appropriate ways to get enrollment in the exchange. And so that's the concept. Third area is we want to make sure that marketing material is fair and balanced. People should understand that there is a regulatory review of advertising material to make sure it's fair. The exchange isn't a regulator. We look forward to meeting regularly with the plans, talking about marketing activities, talking about promotion, and how do we look at the partnering around information versus regulatory oversight, which regulators do, is one of the things we need to engage in discussion with the plans we're working with. Technical needs to link issuers to the exchange and enrollment processes and facilitating all avenues for enrollment. This is a very big issue, and I want to spend a moment on it so people understand its import and some of the both philosophical and technical issues that are before us. Is first, today there are somewhere in the neighborhood of 600,000 exchange subsidy eligible individuals who are currently enrolled in individual plans in California. 600,000, that's a lot of people. We want those people to understand that care can be made more affordable for them through having tax credits. The health plans in which they are enrolled clearly want them to get those tax credits. They also would clearly prefer they stay with that plan if they could. Similarly, many plans make very substantial investments in direct sales, in promoting enrollment in their plan. They do direct mail campaigns, phone campaigns, etc., and they invest a lot. It helps get people in insurance, which I just want to remind everyone is a good thing regardless of where they land. Having a better pool in the individual market, whether or not they're in the exchange, is a good thing. We all want to get everyone insured regardless of where they land. So we want to encourage and promote plans doing ongoing, robust marketing. in discussions we've had with plans, a number have noted that their willingness to invest significantly will be affected if their investments lead, in essence, to placing people in other plans. Not surprisingly, if you're Plan X and you invest a lot of money and you're in essence selling for other plans, it throws off your ROI, return on investment calculation. What we have proposed, and we very much want and need comments on, is to have a mechanism by which if a plan was doing marketing and has a lead, an individual, that is then going to be qualified for eligibility for a subsidy, first, the eligibility process always first determines if that person is eligible for Medi-Cal. If they're eligible for Medi-Cal, then bang, they get to be enrolled in Medi-Cal. And the CalHERS enrollment system will be able to do that or be referred for assistance and service. If they are eligible for a credit in the exchange, and again, the CalHERS, the IT system that individuals will be able to use, web-based portal, as easy as Amazon, you guys all remember how easy it's going to be. Well, maybe not quite that easy, but close. We'll be able to put in people's income, their current status, and then determine what the level of tax credit is and what their plan options are. What we have proposed is, and we're both reviewing this for both stakeholder comment and also making sure this is compliant with the state and federal Affordable Care Act, is if Plan X has done marketing, brought someone in, and then have them gone through the CalHERS process to be determined eligible for a tax credit, that person would be told, here are your plan offerings in Plan X and the value of your subsidy, and a disclaimer online and verbally given saying, in addition, please note, you may have other plans, or you definitely do have other plans that you can use this tax credit for. If you want more information on those plans, either click here or let me transfer you to a customer service person with the exchange. That's the model we're looking at doing. We think that strikes the balance between promoting health plans, making ongoing significant investments in marketing and enrollment, which we think is a good thing, giving consumers information that they have other options than the plan that, so to speak, brought them. And that's sort of the line we're trying to walk. So that's laid out in the board brief. It's an important issue. We welcome people's comments on that element. I will remind people that at prior webinar we talked about issues of agents, the critical role they're going to play with enrollment, et cetera. This is the separate issue of what is often called captive agents, of how might we deal with health plan marketing to promote maximum enrollment in the exchange, but also maximum enrollment in the individual market writ large. Okay? With that, I'm going to go to a couple of the comments that we've had or questions. And again, some of these questions are jumping back and forth on issues we've already spoken about and not specific to what I just spoke to. So Tom Riley, to what extent would the evaluate-based information that employers use to compare plans for employees also be used by individuals to compare plans? Can it be standardized sufficiently to provide individuals a basis for comparison between plans? And again, I note that the quality information we will make available to inform consumers' choice will probably use little from evaluate. That will be HEDIS information, that will be CAHPS information. We will be getting more dialogue on how consistent is that with the Medicare scorecard for plans, the OPA scorecard. The place where we might use evaluate-based information for individuals might relate to, and I want to underscore might, we'll need to look at this, is for information about, for instance, disease management programs, or programmatic description of what plans are doing on behavioral health. So it's less an issue of the sort of high-level plan comparison and more where you get into, so to speak, some of the weeds.
And I would add that the importance of starting to gather the information in year one for Mr. Riley's question is that when we start gathering the information, we'll have a better ability to figure out how we can display some of that information as for consumers to use as they're shopping for plans.
So we have a question from Sandra Barr. Will agents be involved in that lead-in transfer to a specialist? If so, how will this work? My understanding is that when health plans have quote-unquote captive agents and are doing sales issues on the phone, those are licensed agents. They are licensed to sell insurance, and so those would be agents that are dealing with that transfer. The transfer they would potentially make would be to the service center at the exchange, which would be trained navigators, and the issues of licensure of those people is a separate independent issue. We do not believe they need to be licensed. It's an issue we're continuing to look at. Okay? Thank you, Sandra. We have another comment from Rant Quaho Dodgen. I hope I got somewhere close to that. Is noted that all of these are many positive concepts and the direction is right. Noting that affordability is key. How do these metrics, these evaluate other elements, actually lead to additional costs? Are we mindful about what they will cost and what that might mean for making the overall care more less affordable? I would note to people online that at our last board meeting, we had commissioned a study on price elasticity, which basically means how many people do not buy coverage because the price goes up. And as I recall, every dollar increased price means 60 Californians will not be getting coverage in the exchange. So that $1, 60 people. We are very mindful of cost. And one of the reasons we are seeking comment from the health plans and from stakeholders at large is we want to understand what is the burden, what are the cost implications of these initiatives. At the same time, you can't improve what you don't measure. You can't build improvement at the core element of where costs are, which is how care is delivered, where we know there is a lot of waste without understanding what plans are doing in partnership with their plan, their providers, to change the delivery system.
And I also think we should note in response to this question that a lot of the plans in California today are already using Evaluate because the bar has been set by the large employers and the larger purchasers. So we're not necessarily imposing a new burden on the health issuers in California by requesting, by requiring that they complete Evaluate. The question is how much of it is important for year one, and we welcome your comments on that.
Yeah. So we have actually a hand up, someone that's ready to be brave and actually speak out in person. So Andy Weber. Andy, do you have a comment?
Sure, thanks. Can everyone hear me?
Yes, we can, Andy. Why don't you introduce yourself?
Yeah, well, I'm Andy Weber. I'm president and CEO of the National Business Coalition on Health, and let me say I've certainly appreciated all the comments about Evaluate. NBCH is where the Evaluate tool.
Andy, can you turn off the speakerphone and maybe pick up your phone?
Is this better?
Yeah, turn your speaker down. There you go. You're doing great.
Okay. Well, again, Evaluate is where, you know, I'm getting incredible amount of feedback.
You sound clear on our end.
Okay, well, I'll continue on. Again, appreciate all the discussion of Evaluate. I did want to mention Evaluate is where NBCH is the home of Evaluate. NBCH, so folks who don't know us, is a national nonprofit membership association of 56 employer-based coalitions, including the Pacific Business Group on Health, located in California. And like your description of the exchange, our membership is dedicated to the triple aim of improving health, improving health care, and lowering costs. Peter, you and Emma have done a great job of describing the Evaluate tool. And just want to mention that it is a wholly owned tool of NBCH that we maintain and that we operate, and we use in conjunction with our coalition members and a national network of 7,000 employers around the country. And let me just say a few things from a policy perspective of why I think Evaluate might be a useful tool for the exchange to consider. And I think some of these comments have been alluded to already. First, and very obviously, it is an existing tool, so you don't have to do anything in terms of developing a new tool from scratch. As just been mentioned, it's a tool that's been used in California in the private sector, so I think both health plans and purchasers are already familiar with and have used the tool. And very much related to this point, if the California Exchange were to use a tool that is now in use in the private sector, I think that sends a very consistent and aligned message to healthcare plans that all the purchasers in a state, in a community, are aligned around a standardized set of plan expectations. Just a few other points. As been mentioned, Evaluate information will be principally, or can be principally used to set performance expectations, but do look at it in terms of information that can be used to feed consumers in their selection of healthcare plans. Another point, Evaluate works off a pretty dynamic technology platform that allows plans in a very efficient way to update their information anytime they want to. So they can fill it in once, but as they make changes in their program, they can come into the tool and update that. And that also allows the exchange to go into the database and extract information on an ongoing basis, not at any singular time during the year. And then the final point is the use of Evaluate is flexible. And that is, you might choose to use all of Evaluate, as you've discussed today, or certain modules of Evaluate or sections of Evaluate. And again, the technology platform, and certainly we'd be interested in working with you on just those elements that are of particular interest. And let me also close by saying that if you're interested in adding new questions to the Evaluate tool based on public comments or areas of interest, we'd be very much interested in working with you on how to make that happen.
Great. That's perfect, Andy. That's a great note. So when people are looking at the Evaluate tool, thank you much for joining us, Andy, is if there's a module that you like, but you say it's missing an element, I think it's an important note that Evaluate itself is a learning instrument. It's been improved and changed over time. I would also note that a number of the elements, such as on disparities and on behavioral health, have been supported with substantial resources from the Centers for Disease Control. And so that it is already a model of public-private partnership. We've got a couple other comments that if people are going to drop off, I want to remind everyone that we welcome, want, and need your comments. We'd like to have those by close of business on Monday, August 6th. There's a stakeholder input form on our website that you can use, so we take it, if you write it on the back of a banana, we take it on letters, we take it whatever, but we prefer the input form. So we have a couple other comments. So a comment question from Kevin Knaus is, can you just reimburse the insurance company a flat fee for transferring a consumer for a tax-subsidized plan versus a percentage on marketing dollar reimbursement, sort of like Google Ad Pay or per click? And let me just sort of underscore something to Kevin about reimbursement or not reimbursement for enrollment. And again, this is not a qualified health plan issue, but it's a broader issue on enrollment. The exchange has adopted a interim policy to, number one, pay navigators. consumer groups that are trained and certified to help people enroll. We have a payment amount at $58 per enrollment that they would get paid. We have also acknowledged and celebrated the important role that agents play. Agents can be compensated by health plans in which the individuals end up enrolling in the exchange. Agents, like navigators, the paid assistants to the exchange, will be required to help everyone understand their eligibility for Medi-Cal. Will be required to provide a full range of what all the plans available in the exchange are. Under this proposal relative to health plans, it's a little bit different. We would not be paying a health plan anything for them referring someone to the exchange. We would be requiring the plans to make it known that there are other choices available, but not walking through the whole range of what all those choices are. So it's a little bit of a different model here, but just as we will be having many individuals who go right to the website and enroll directly, this is another avenue that we want to be promoting to encourage maximum enrollment. Okay? Thank you. There's a comment/question from Mark Blum. Is that there seems to be a consensus that the board seeks to encourage provision of team-based or medical home care options. If it turns out that evidence demonstrating high performance in terms of quality and cost is right, then qualified health plan level, price, and quality information will be insufficient to allow consumers to make rational choices of team-based care based on comparison of team-based delivery options with non-team and non-medical home options. So, will the board consider presenting comparative information that will allow cost and quality comparison between team and medical home care and those that are not team-based options? It's a really good comment, and it's one of the things that I think that, Mark, you're right, that in many discussions the board has had the recognition that healthcare is a team sport, and that there's some very important initiatives around from the highest level, such as accountable care organizations, to the more granular level, primary care, team-based homes, et cetera. How do we communicate that to consumers? It's a good question. It's one that the exchange will look at, sort of best evidence for engaging consumers and making the best choices for them. So I think it's a good comment, one we will look at with others about how to best inform consumers to make the right choice for them. We have no other comments pending right now. I'd like to see for a moment if Susan or Paul have any other comments or questions for us while we're on the line.
I have some questions about some of the definitions, but they're fairly naive, I think, because I'm not as expert as many others are. But I want to go back to the concept of the cost of care being available to consumers.
Yep.
I think someone asked the question about whether it was full cost or whatever, but could you define that for me? Because I'm trying to think of this as a consumer of healthcare myself, and I'm not sure what information you could give to me that is relevant, since I pay a monthly. Well, I'm on a high deductible plan, so I do ask questions about what this MRI is going to cost or what is out of my pocket. But try to explain that concept to me from a consumer's perspective, and what we would incorporate into the qualified health plans.
Yeah, the idea here, what we incorporate in the qualified health plan, is to say that you as a health plan need to provide tools and information so Susan, who is enrolled in my plan, understands if I'm going to get an MRI, what that means to me in terms of my out-of-pocket exposure, what the total cost is. Or if I, Susan, who have been very athletic, but now my knee's getting creaky, need a knee replacement, would understand that here's 4 places I can go for a knee replacement, and this one costs $29,000, this one $48,000, and you're out of pocket from choice A versus choice B is $2,300 versus $6,500. So it's trying to get as consumer relevant. It's not policy wonk. It's not abstract. It's trying to be spoken in terms of the amount paid by the plan and that amount for which a consumer, given their benefit design, would be obligated to contribute for a particular episode or type of care. I think Andrea has a little texture to add to that.
Well, a couple of things. This has become kind of a hot topic right now in terms of the ability or lack of ability of consumers to, quote, shop for the best price and understand what their share of cost is going to be. A lot of this has to do with, obviously, elective procedures, not emergency. It also has to do with the place of care. So, for example, if your doctor is recommending an elective surgical procedure for you that's medically necessary, you can go to an outpatient surgery center. You could sometimes go to a doctor's office, or you can go to a hospital. And I can tell you from personal experience, it's almost impossible right now to actually call up those three facilities, say, I have this health plan, I'm going to have 30% coinsurance, and actually find out which setting. All of them would be equally, let's just say for practical purposes, all of them would be of equal quality, and to find out what my 30% coinsurance will actually cost me at the hospital versus the surgery center versus the doctor's office. So what we would be looking for as part of our QHP selection process, ideally, would be how good is the plan at making that information required to be available to a consumer when they're shopping for where to have their elective surgery and with which provider and with which place of service, for example.
Got it. Got it. Thank you. Can I have two more questions?
Yeah, please, Susan, go ahead.
You mentioned provider-level performance, kind of measuring provider-level performance. Can you give me some concept of the metrics you would use for that, particularly as it might affect facilities that accept very high-risk patients, such as City of Hope?
That's a great question. There's been actually a lot of work in California and around the country on different measures of, in particular, hospital quality, whether it's regard to particular conditions or not with regard to specific conditions, but with regard to, for instance, rates of hospital-acquired infection. In each of those measures, there's a long science to do what's called risk adjustment to make sure that if a particular hospital has a sicker population, is a particular higher, different acuity, that is adjusted for in the provider measurement. It's it is part of both the science, an evolving science, but it's a central piece of you don't want to have a provider dinged, so to speak, because they're seeing a tougher population.
Is there an instrument that takes into consideration acuity that is considered best practices and that works?
Yeah, it's really, unfortunately, it's a measure-by-measure issue rather than an instrument. So it depends on what the measure is. And so, you know, there's been in California something called CHART, the California Hospital Reporting something or other. There are other reports, and that group, which has a lot of hospitals and others at the table, have spent long hours making sure that the risk adjustment on a measure-by-measure basis are done appropriately. I will note, Susan, and this is really an important issue when we look at the health plan level. The same issue comes up when we talk about HEDIS, which is a health plan, both process and outcome quality score, or CAPS, which is a patient experience score. There is some significant concern that health plans that serve a lower income population or a population with less English speakers generally get, quote unquote, worse CAPS scores. So do we need to look at adjusting scores? The issue about, quote unquote, risk adjustment is relevant to us at the plan level as it is at the provider level.
Okay. Then the last question is on transparency with regard to provider contracts. Can you tell me what issues would not be subject to transparency?
No.
Such as negotiated bed rates.
Oh, absolutely. Yeah. Rates would not be. The concerns around transparency are contract provisions that have said you, Health Plan X, cannot use the data that you receive from us to generate a quality report card on our hospital. But absolutely, plans and providers have the right to say, keep my negotiated rates non-transparent.
Why? I'm
well,
in favor as someone in favor of full transparency, why would that be? Why would the negotiated rates be?
Well, it's been what has been the norm. Part of our push, and I'm not going to dive into all those reasons why, what we're trying to push, though, is whatever the negotiated rates are, negotiate them. We want consumers to know exactly what they're going to pay. And so where we focused on is, again, the potential of requiring plans to make available true cost information based on what the benefit design is, based on the negotiated contract. So that's how we've tried to approach it. Make some sense? And I will note that Kevin Knaus on this area notes that Anthem Blue Cross has a cost estimator on their website, but it doesn't have a co-insurance field. But it gives an overview, and Blue Shield has a cost estimator, but you must be a plan member to access it. So again, we know that plans have these cost estimators. Some of them you can test out. Others you need to be a member of the plan. From our perspective, what we're recommending to the board is that to be an exchange plan, you need to help individuals understand what the cost of care is going to be, which is always specific to someone's circumstance. I need a new hip. I need whatever it is. So it's not the generic issues is a piece that doesn't get to it. So I want to see if Paul Fear has any other comments or questions.
No, I'm okay for now.
Okay. We're actually running out of time. We have a number of comments that really relate to outreach, marketing, use of agents, navigators that we don't have time to get into, but we welcome and relish. I want to wrap up by first thanking Andrea, the team at Pricewaterhouse, Sandy Hunt, Emma Hu, Pete Davidson, Susan Murphy. We've had a team effort here in addition to Andrea, Leah Morris, Amy Krause, who has been embedded with us from the Department of Managed Healthcare, Lisa Howard, and it really is a team effort of literally hundreds of people around the state weighing in with your thoughts and suggestions. As you look at these issues and the others we have shared at our board meeting in July and at the webinars, we welcome and ask for your comments. I would encourage you to be as specific as possible. It's much better to say, do it this way and include this module and these questions than say, we don't like that. So it's really, we are, as you all know, moving quickly. We are seeking to provide an example and partner with other states. We are in discussion with other states to learn from them as well. But to move this quickly, we need your engagement as constructive partners, which means get as specific as you can. And with that, I want to thank the more than 150 people who joined this call today for joining us. For those that we didn't get to, your comments and questions will inform us going forward. Thank you to Paul Fear and Susan Kennedy, two of our board members who joined this call, for your time now and in general. And we wish all of you a good week. Thank you for joining us, and weigh in on our website. Thank you all very much.